Thank you, David and Axel, for the nice introduction. Glad to be back for this very nice symposium. Maybe next year, David, you can consider moving the HCC session a little bit earlier, yeah, so that maybe we can have a little bit more audience here, yeah. In any case, I'd like to take the opportunity just to touch base a little bit, what's new in HCC. I think, one of the latest advancements is actually not happening in the oncology field, but rather in the hepatology field. And that is the eradication of hepatitis C with very effective therapy. I just want to shed some light on the potential link for what we do in the oncology field. Discussing very briefly the current landscape of HCC target therapy and also, what we have learned from the failed phase 3 trials. And finally, just touch base a little bit about the potential new targets. And this is a very common cancer on the international global scale. It's the 6th most common cancer, but also it's important to realize this actually has surpassed gastric cancer as the 2nd most common cause of cancer-related mortality. And also, for those of you, who wants to take a closer look at the incidence of HCC in the States, this is a very important article that just came out to Cancer. This is the annual report from the NCI CDC American Cancer Society looking at the incidence of various cancers in the States. In contrast to most other cancer types that either actually going down or stable in terms of the incidence, liver cancer is actually rising as the fastest rising incidence, secondary only to thyroid cancer. So I think it's very important for the community to appreciate this disease. The tumor is very heterogeneous. There are multiple reasons contributing to the heterogeneity, but I think the underlying etiology and also the molecular mechanism driven by each particular risk factor that leads to the different hepatoparthenogenesis pathway clearly contribute to the heterogeneity. On the global scale, HBV hepatitis B infection is by far the most common etiological risk factor. And also, we have an effective vaccine strategy to prevent patients getting the hepatitis B. However, at this point, we can only control the viral infection for the hepatitis B without being able to eradicate the virus. In contrast, the hepatitis C virus, which is really the leading cause of HCC in this country, is a very important risk factor. This is actually the natural history highlighting the natural history of hepatitis C infection. Upon exposure to the virus, most patients will actually get the chronic infection, and also a significant number of patients, up to 20%, will eventually develop cirrhosis. And also with time, the cumulative risk to develop hepatocellular carcinoma is increasing at the annual risk perhaps in the order of 3 to 5% annually. So you can appreciate that with time, the risk for patients with underlying HCV to develop HCC is really very, very significant. This is the genomic structure for this virus. It is an RNA virus with both quite a few structural proteins as well as non-structural proteins. Suffice to say, some of these have been exploited for effective anti-HCV therapy, particularly those targeting the non-structural proteins, including the RNA polymerases. What's really striking, without going through a lot of the studies, is really in the past few years, there are quite a lot of the drugs against hepatitis C that actually has very effective sustained viral response for hepatitis C infection. This is just to highlight one study looking at one regimen, the sofosbuvir, in the context of either interferon with ribavirin or the sofosbuvir in combination with ribavirin, and also the other arm with the PEG plus ribavirin. You can appreciate in the middle column, and even with the interferon-free regimen, the 12-week sustained viral clearance is up to 67%, which has really opened the door to develop a non-interferon-based oral regimen. This is actually further highlighted by multiple latest development of a lot of the oral agents. This is actually just one of the key studies looking at two of our oral agents. You can appreciate that this is the so-called NS5A inhibitor. And you can also appreciate that in these non-interferon oral agent regimen, the sustained viral release, a sustained viral control rate at 12 weeks is actually more than 95%, which is really quite striking that you can actually eradicate this virus very effectively. So what's the goals of the HCV therapy? I think clearly we can actually declare the cure for this virus. We can perhaps prevent the cirrhosis as we eradicate the virus, prevent the decompensation of the cirrhosis, and also for us, perhaps this can actually impact the development of hepatocellular carcinoma. We can reduce the requirement of liver transplantation in patients with chronic hepatitis C. And also, I think for us, doing the clinical trials for the advanced stage disease, I still think there may be room that we can actually use the hepatitis viral therapy to improve the hepatic function so that some of these patients perhaps can become eligible for clinical trials because of the normalization of their underlying hepatic function. But obviously the cost is a major issue in this setting. And also, somewhat unanswered question, is in the combination of anti-HCV therapy with the known hepatocellular carcinoma therapy will actually even improve the outcome for the hepatocellular carcinoma, and also the improvement of the quality of life for patients with hepatitis C. So the data of hepatitis C management for the HCC burden is actually not very well examined at this point in the prospective trial. However, I think the data perhaps will be emerging. This is actually a retrospective study from Europe looking at the interferon-based therapy to control HCV in many, many centers consisting of 530 patients. And for those who actually receive this regimen, you can actually assess their serological viral response or no serological viral response, and then follow these patients up to 8.4 years, looking at the various complications related to HCV. For example, the need for liver transplant, the development of hepatocellular carcinoma, and also the liver failure rate. If you just focus on the hepatocellular carcinoma development at 10 years, the annual risk for HCC development is actually 5% versus 22% in patients without with the SVR versus those without the SVR. So clearly suggesting as we continue to use the anti-hepatitis C viral therapy, perhaps the HCC burden can be reduced. With that, I'd like to come back, for the management of this disease. I think, there's really no doubt in this tumor, the early diagnosis leads to the improved outcome that can be rendered either by surgical resection, liver transplantation, or percutaneous acidoid injection, radiofrequency ablation. And the cure rate can be up to 70 to 80% for those patients who meet the stringent criteria. This is incredibly different from what you just heard in the previous session for pancreatic cancer. Even when you have a very favorable cancer diagnosed at the early stage, you send the patient to the best surgeon in the country, you will not even be able to get very close to what you get with liver cancer. Again, arguing this cancer needs very improved recognition so that we can detect the cancer early to improve the outcome. Intermediate treatment defined loosely by the presence of multifocal disease without vascular invasion is a very important field, for local regional therapy. I think Dr. Brown is going to highlight quite a lot of the different treatment modality. And also, we have some emerging data with radiation in this setting. I think Dr. Crane is going to comment on that as well. And when you have the advanced stage disease, unfortunately, this is still an area that we actually desperately need effective drug therapy. And I think, you all know the data from the sorafenib. These are the two key phase 3 trials that led to the demonstration of the success of sorafenib and also the successful approval of this agent. In these two trials, we know that given sorafenib in comparison with placebo, will give you a median overall survival from 2 to 3 months from two phase 3 trials in patients with underlying Child-Pugh A. And we have learned quite a lot over the past several years because this is the only agent that we're able to access for patients who have no other treatment options. We know this drug is modestly active in patients with Child-Pugh A cirrhosis. The data for Child-Pugh B is still somewhat controversial. The toxicity management and dose adjustment are absolutely critical to make sure these patients can benefit this agent. I think the outcome certainly appears to depend on the etiology, geographic region, and also the severity of the underlying cirrhosis. I think for all of us, particularly in the era of precision medicine, we'd like to know more, what determines the sensitivity or the resistance to this agent. Unfortunately, the data is still not very clear. So that's why all the clinicians who is doing the sorafenib management, right at this moment, we do not have anything to guide us, who is likely to benefit from this agent. There are some earlier efforts, trying to dissect, whether there are some potential predictive markers. The early data for the nuclear phosphorylated ERK seem to have some predictive value for the prolonged TTP in phase 2 trial. Unfortunately, this did not pan out in a phase 3 effort. And this is actually, there are some circulating biomarker efforts looking at various circulating biomarkers predicting the efficacy. Suffice to say, from the SHARPS trial, only the baseline high soluble c-KIT and low hepatogrowth factor appears to correlate with the trend of improved overall survival, but this is not going to guide the clinician, for the daily practice. There are some very interesting genomic efforts looking at a very small subset of patients with extreme response to this agent. There are data linking the FGF3 and FGFR4 amplification in terms of predicting the response, and lately the VEGF-A amplification. This is the Japanese data looking at a few super responders to sorafenib. They were able to identify that the FGFR3 amplification appears to predict the response in these patients. Very small cohort. And also very nice paper published, both from the preclinical side as well as some correlation in the post-resection setting, looking at the potential value of VEGF-A amplification in terms of predicting sorafenib response. Again, I would say the data needs prospective validation. So we all know that, over the past 8 years, even though we have made a lot of efforts, trying to move forward with additional agents, I think, unfortunately, this is a very sombering field that we have actually failed multiple efforts, both in the first-line settings, trying to compare various target agents against sorafenib, or in the second-line setting when patient could either not tolerate the drug or actually have definitive progression following sorafenib. I think, I highlight, all of the here in case that you want to answer your question carefully in the first line. And definitely sunitinib has not actually been shown to be equally effective or better. If anything, this is actually inferior. Brivinib in the first line, lenvatinib, and also the combination of erlotinib plus sorafenib. And in the second line setting, we have the brivinib and also the everolimus that's actually compared with placebo in the second line setting, and both were also negative. Interestingly, in the second line setting, that the brivinib trial was able to show the improvement for time to tumor progression, but unfortunately, the median overall survival failed to reach the statistical significance. So from these phase 3 trials, I think collectively, we actually have learned quite a lot, in my opinion. I think, one thing that we have actually learned is that, you have to be very careful assessing the single agent phase 2 efficacy signal. I think, due to the heterogeneity, I think single arm phase 2 trial data tends to be very difficult to interpret and also sometimes can be incredibly misleading. We also have painfully learned that we don't have a very good surrogate endpoints to assess the good endpoint that may potentially correlate with the overall survival. I think we failed miserably with the overall response rate, but also, lately, either the TTP or PFS, does not seem to correlate with the overall survival. And also for hepatocellular carcinoma, I think we're increasingly humble to realize we need to test drugs that actually have safety profile. You cannot test a drug that's actually incredibly potent, but as a result, that actually worsening the underlying hepatic function. These drugs, will fail miserably in this disease. And obviously, the biological and clinical heterogeneity of HCC is definitely really catching more attention as we move forward in how to design the next generation of target agents. And we are making the efforts. I think, of all the classes of the drug that have been implicated, in hepatocarcinogenesis, we're actually really moving very fast over the past few years to test them. I'll try to highlight a few examples. I still think, the antigenic agents, perhaps will have a role at least in selected populations, even though the benefit may be on the modest side, as we appreciate from this symposium, collectively in all the GI cancer. This is just not unique to HCC. I think this is unique to colorectal cancer, gastric cancer. I think the anti-angiogenic agents perhaps, can only bring so much benefit. But having said that, it's still worthwhile, whether we can validate this class of agent, at least in selected population HCC. I think there are two drugs that are actually still ongoing. The first one is the ramucirumab, which is really the unique monoclonal antibody against VEGF-R2. And there is a single-arm phase 2 trial showing very impressive, single-agent activity with 10% response rate, PFS 4 months, but also overall survival 12 months. Lenvatinib is another interesting agent. It's a multi-targeted tyrosine kinase inhibitor. In addition to VEGF-R1, 2, 3, it also has a few other potential targets that's relevant for hepatocarcinogenesis. And these two agents have all been actually subject to phase 3 effort. And this is the published REACH study that's actually looking at ramucirumab against placebo in the second-line setting. And this slide highlights the study design. As you all know, the trial is actually negative in the intent to treat population. The median overall survival for the placebo arm was 7.6 months, and for the RAM, it was 9.2 months with a hazard ratio of 0.866, and the p-value was 0.1381. So this was definitely a negative trial. If you look at the secondary endpoints, including the overall response rate, disease control rate, or actually response rate, all these were actually in favor of ramucirumab. And also, what's really very intriguing is that, in the protocol pre-specified subgroup with those, with alpha-fetoprotein level above 400 nanogram per ml, and this group of patients is really highlighting a poor prognostic group. As you can appreciate, in the placebo arm, the median survival was only 4.2 months, but in this particular group, which accounts for about 40 to 50% of the patient, the median survival was improved to 7.8 months. This was actually leading to a hazard ratio of 0.67. In contrast, if you look at the patient with AFP less than 400 nanogram, ramucirumab clearly has no benefit whatsoever in that subgroup. So because of that, ramucirumab is actually undergoing a reevaluation in patients with the high AFP signature defined by 400 nanogram per ml. And the so-called REACH2 trial is currently ongoing. There are multiple agents targeting the mTOR PI3K pathway. I think, for HCC, this is a very importantly implicated pathway. We have a lot of very good preclinical translational work highlighting the relevance of the dysregulation of this pathway in hepatocarcinogenesis. And I think the effort is still ongoing. For example, this phase 1 trial highlighting the oral TORC1, TORC2 agent in hepatocellular carcinoma. This is actually one example of the scan showing a very impressive radiological response. As highlighted on the left side of the panel, the drug definitely has predictive pharmacodynamic biomarker changes. So I think, in my opinion, this class of the drug perhaps deserves a reevaluation, but on the other hand, the challenge for this class of the drug is really to make sure we know, how to select the right population so that, perhaps only selected patients will benefit from this class of agent. I think in year 2016, if you ask me, what's really on the horizon for HCC, I definitely think, we need to evaluate the immune-based therapy very critically. For the sake of time, I will not deliberate the rationale why immunotherapy is relevant, but suffice to say, there are multiple ways actually thinking about the strategies that we can actually exploit so that we can actually augment the immune response against hepatocellular carcinoma. By far, I think the most mature strategy is pretty much following the success that we have seen with checkpoint inhibitors in other tumor types. And for HCC, I think so far the success, the clinical experience has been limited to the CTLA-4 inhibitor, tremelimumab, and also the reported data for the nivo. Now, for the CTLA-4 blockade with TREMI, the data was only obtained for patients with underlying hepatitis C infection. This is a single-arm, very small trial with 20 patients. Of these, only 17 patients were evaluable for efficacy. The authors reported a 17% response rate, and the disease control rate at 76%, and the time to tumor progression was at 6.5 months. Interestingly, even though there was some concern that this class of drug may actually have some concern for flaring the underlying hepatitis C, in contrast, this agent was actually proven both safe, but also was able to reduce the hepatitis C viral load. So very intriguing data for this agent. And obviously, the most mature data perhaps is regarding nivolumab that's actually reported in last year's ASCO. I think to give the credits for the investigators, they have preceded this phase 1/2 trial very, very logically, but also focusing on the specific population. Starting from the uninfected population, going to the HCV and then the HBV population with dose escalation. Perhaps because of that, the trial has actually taken a little bit longer time than we would like to get the early efficacy signal. And this is the reported data. As you can see, only 42 patients got the drug. Of these, right now, we have 19% of the response rate of all comers, including 5%, 2 patients with complete response. And the etiology was actually defined there. You can see the response definitely occurred in the HCV subgroup and also in the HBV subgroup. And also these responses tend to be relatively durable, and also it occurred in patients who actually discontinued the treatment, and the response can actually continue much longer. So obviously, this opened the door to explore quite a lot of different questions. How do we move forward with a checkpoint inhibitor in HCC? I think some of the points that perhaps worth discussing, that if we have the time, is what really predicts the subpopulation that actually responsive to this class of agent. Clearly, it's perhaps not just based on the clinical variables. I think the efficacy perhaps will be present in different etiology. Whether there will be any specific biomarker that will actually help us to predict the response to this particular agent. And also, can we move forward, start thinking about testing other PD-1, PD-L1 inhibitors in this setting, and how do we rationally combine this class of drug with either other immune-based therapy, with target drug, or even potentially other chemotherapy. So all these are obviously currently ongoing efforts. You will see a lot of the checkpoint inhibitor-based trials either at your center or in the centers that you are affiliated with. The other potential strategy is really to think about whether the cancer stem cell theory is holding true for HCC. I think the theory is that you can perhaps kill the cancer cells, but as long as you have the cancer stem cells present, if these cells are not eradicated with time, they can actually repopulate, contribute to the regrowth of HCC. And there are various different strategies, how to target this pathway. I think, there are definitely some agents with putative stem cell inhibitory property that's actually being examined in HCC, but the data is definitely not there yet. I think to follow the same paradigm with other molecular target therapy development in oncology, we have actually tried to exploit, the oncogene addiction theory, trying to see if we can identify the specific nature in HCC and trying to match the right drugs with the different signature HCC. And the genomic effort is here. We have actually tried to exploit the genomic signature of HCC quite extensively with very, very elegant efforts from many groups. And suffice to say, we have definitely come to realize HCC is heterogeneous depending on the genomic signature. We can clearly classify them depending on the underlying mutation signatures. But also, when you look at the frequency of most commonly observed tumor suppressor genes or oncogenes, and the most actionable signature are actually relatively rare. Those that are consistently present, for example, P53, we still don't know, how to really, find the right target, to target these particular signatures. So overall, even though the genomic effort is here, I still think, we have actually not come across the right strategy with the best proof of principle trial to highlight this strategy. And also, even though we think there are a lot of variations that we think, we have the right drugs to match, I still think, even when we combine all of them, we still at the very early point to demonstrate the success. Even though we think there are putative actionable targets, and also we have the agents, some of these have actually failed miserably in the field. So I think, this strategy, in my opinion, still deserves, very, very careful investigation. There are several efforts still ongoing trying to look at this strategy. For example, we're making the efforts trying to see whether c-Met amplification or overexpression perhaps can help us to identify the subpopulation. There are early efforts trying to see whether we can target the RAS mutation signature, which is present in about 5% of all HCC, using the MEK inhibitor in combination with sorafenib. Unfortunately, even though there are some early report in the phase 2 trial, this strategy actually did not pan out to be the way we like in the expanded cohort. I think several groups have actually focused this particular signature, that is the FGF19, fibroblast growth factor 19 amplification, because we do have very good FGFR4 inhibitor. So the idea is trying to see whether we can enrich the population based on the FGF19 amplification, either alone or along with the FGFR4 overexpression signature to identify the subpopulation who may likely benefit from this class of drug. The data is still very, very preliminary. The c-Met axis is a very important pathway. We can actually identify either the mutation, amplification, or the overexpression. I think for HCC, the mutation rate, amplification rate is actually very, very low in comparison with other cancer types. And so these are the drugs that we're currently testing in HCC. Agents that either target the ligand or the receptor with multi-targeted tyrosine kinase inhibitor, or relatively more selective c-Met inhibitors. For the sake of time, I think I'm going to highlight just some examples. I think this is the tivantinib data that you all know from the randomized phase 2 trial. It is very controversial whether tivantinib should be viewed as a true c-Met inhibitor. But I think let's put that on the side. You can appreciate if you take all comers on the left panel, the drug doesn't seem to do a whole lot, but only for patients with high c-Met expression, and the agent seemed to actually improve both the median survival shown on the lower panel and the progression-free survival on the top panel. So because of this very relatively small data set from a randomized phase 2 trial, this agent is definitely undergoing phase 3 effort. Hopefully, the final readout will be available at the end of the year. And this is definitely a drug that's actually looking at the enrichment strategy, looking at patients with high c-Met expression. Cabozantinib is a multi-tyrosine kinase inhibitor, and one of the targets is definitely c-Met. This is the randomization discontinuation data from the single-arm phase 2 trial showing the agent appears to have some single-agent efficacy, and currently this drug is undergoing phase 3 effort as well. So I think moving forward, as we apply these molecular target agents in HCC, I think we definitely need to exploit the signature of these tumors more carefully. I think unfortunately for HCC, we have the inherent difficulty of obtaining repeat biopsy. So that's why, personally, I like to see, the potential value of the liquid biopsy to be applied more in HCC. So perhaps we can actually use the liquid biopsy to guide us how to interrogate the molecular signature, both to guide us to select the right drug at the beginning, but also, perhaps we'll shed some light, when some of these drugs have some efficacy, we're trying to interrogate the resistance mechanism in the future. But I do think, in contrast to other tumor types, we cannot ignore the tumor microenvironment for HCC. I think, the molecular signature-driven type of efforts, perhaps, will gain ground, when we can actually demonstrate a few proof of principle successful examples. But to have an agent that has actually broader activity, I think, we have to think about the tumor microenvironment for hepatocellular carcinoma. And unfortunately, I think this is still at the very early stage of experiments. These are the current efforts in the phase 3 setting, which obviously are potentially practice changing, so that it's important to keep an eye on the results for these trials. And unfortunately, the intergroup effort, looking at the addition of doxorubicin to sorafenib versus sorafenib plus placebo has been declared as a negative trial. So there's really no role adding doxorubicin to sorafenib in the first-line setting. The lenvatinib against sorafenib phase 3 trials is still currently ongoing. Hopefully, we can actually hear the results, pretty soon. And nivo is currently ongoing to be compared against sorafenib in the first-line setting. Then we have some very extensive efforts in the second line, particularly tivantinib, regorafenib, cabozantinib, and ramucirumab. Of these, only the tivantinib and ramucirumab were looking at select population. The tivantinib is based on the c-Met expression, and the ramucirumab is based on the high AFP signature. So I think, these trials, will mature, and I think, for those trials, that's still targeting the unselected population, I still think, perhaps these trials, will be actually at a higher risk for failure just based on the single-arm phase 2 trial. But hopefully, in the next year or two, we can actually see some successful example of certain target agents, at least in the selected population. So with that, I just want to conclude. I think anti-hepatitis C viral therapy definitely holds the potential to impact the outcome of hepatocellular carcinoma. Unfortunately, sorafenib remains to be the only approved systemic agent, even after 7 to 8 years of extensive efforts by many investigators. I still think angiogenesis pathway is important, and also the experience in the phase 3 with lenvatinib and ramucirumab should definitely be eagerly awaited. And the early experience with the c-Met and mTOR inhibitors are intriguing. I think we definitely need to see the mature data, and also to get a better sense what really predicts the clinical efficacy of these class of drugs. I think immunotherapy has emerged as a very exciting therapeutic strategy, but I think it's still very early for us to reproduce the clinical efficacy signal, but also to get a better sense about the tolerability and how can that guide us to combine this class of drug with other agents in this population. I think we should definitely explore other novel agents with unique mechanism of action in HCC. We should definitely keep a very open-minded approach for this disease. And finally, I do think the molecular classification, the predictive molecular markers should definitely guide us, at least to produce some positive proof of principle trials to guide us, whether we can actually go after a specific subpopulation of a hepatocellular carcinoma. With that, thank you for your attention.